I am Manoj Nayak. Today my topic is bronchiectasis, emphysema and lung carcinoma, gross and microscopic pathology. Introduction to chronic lung diseases, obstructive versus restrictive. Obstructive disorders characterized by an increase in the resistance to airflow due to the partial or complete obstruction at any level. Neoplastic disorders. Lung cancer remains the leading cause of cancer-related deaths worldwide, with distinct morphological subtypes that guide clinical management. Bronchiectasis, chronic infection and irreversible dilation. Pathogenesis. The development of bronchiectasis involves two major components. One is obstruction and other is infection. Initial insult, bacterial or viral infection, impaired clearance, mucus stasis, inflammation, wall destruction, and finally it is permanent dilation, bronchiectasis. Key etiology of bronchiectasis: post-infectious, congenital and bronchial obstruction. Morphological classification: cylindrical. Airways are enlarged uniformly without tapering, most common and mildest form. Varicose. Irregular dilation and constriction resembling varicose vein on imaging. Cystic type. Severe dilation ending in large blind sacs. High risk of honeycombing appearance. Gross pathology. Distribution. Most common in lower lobes. Bilateral in case of systemic or localized if due to obstruction. Airway dilation. Bronchi can be dilated up to 4 times their normal diameter. Pleural extension. Dilated bronchi can be traced almost to the pleural surface. Contents. Dilated spaces often contain thick mucopurulent foul-smelling exudate. Microscopic features. Key histological findings of bronchiectasis. Inflammation. Intense acute and chronic inflammatory exudate within the walls. Epithelial changes. Desquamation of lining epithelium or squamous metaplasia. Necrosis. Extensive ulceration of the bronchial wall. Fibrosis. Replacement of muscle and elastic tissue by fibrous tissue in chronic cases. Next is emphysema. Alveolar destruction and hyperinflation. The protease antiprotease hypothesis. Emphysema results from the destruction of elastic tissue by proteases, that is elastase, released from the neutrophils and macrophages. Increased protease smoking induces neutrophil recruitment and activation, leading to high levels of elastase. Decrease antiprotease. Congenital alpha-1 antitrypsin deficiency or oxidative inactivation by smoking fails to neutralize elastase. Unchecked elastase activity leads to degradation of alveolar septal elastin. Classification of anatomic distribution. Type: centriacnear, central or proximal achinous. Heavy. It is associated by heavy smokers by upper lobes. Panacinar. The region affected is entire acines from bronchiole to alveoli. Alpha-1 antitrypsin deficiency. Paraseptal, distal part of achinous. Spontaneous pneumothorax in young adults. Irregular type. Random involvement associated with scarring. It associated with healing of inflammatory processes. Gross pathology of emphysema. Panacinar. Pale, voluminous, hyperinflated lungs that may obscure the heart. Centriacnear. Dark, distended air spaces in the center of lobules, surrounded by normal parenchyma. Bullous emphysema. Large subpleural blebs or bullae, which is more than 1 cm, often seen in apical paraseptal types. Microscopic features of emphysema. Key histological findings: enlarged air spaces, abnormally large simplified air sacs, septal destruction, thinning and rupture of alveolar walls, broken spores of septal tissue project into the lumen of the enlarged spaces. Athracosis. Accumulation of carbon pigment is often seen in centriacinar types. Minimal fibrosis. Absence of significant scarring differentiates it from ILD. Next is lung carcinoma. Epidemiology and classification. Classification of lung tumors. Lung cancer is broadly categorized based on therapeutic implications. Major category: non-small cell, that is NSCLC. Subtype: adenocarcinoma, squamous cell carcinoma, large cell carcinoma. In case of adenocarcinoma, the location is peripheral. In case of squamous cell carcinoma, the location is central. In case of large cell carcinoma, it is undifferentiated peripheral mass. Next, the major category is small cell carcinoma. The subtype is Wood cell carcinoma. Location in the central. It is highly aggressive. Squamous cell carcinoma. Gross and microscopy. Gross. Large central hilar mass often undergoing central necrosis and cavitation. The microscopy. Nests of polygonal cell keratin pearls, laminated walls of keratin, intercellular bridges, desmosomal attachments, individual cell keratinization. Next is adenocarcinoma. Gross and microscopy. Gross. Typically peripheral location often involving the pleura, scar, carcinoma association. Microscopy. Glandular pattern formation of acini, tubules or papillae. Mucin production. Cells often contain intracellular mucin. Lipidic pattern. Tumor cells grow along the walls of the intact alveoli. Small cell carcinoma. The Odd cell tumor. Gross. Centrally located, often infiltrating the mediastinal lymph nodes and hilar vessels. Microscopy. Small cells with scanty cytoplasm, nuclear molding, tight nesting of nuclei, salt and pepper chromatin, typical neuroendocrine features. Next is the hilar mass presentation. Lung carcinomas arising in hilar region present as firm gray-white masses that distort the anatomy of main bronchi. Invasion into the bronchial wall leads to the distal collapse, obstructive pneumonia or secondary bronchiectasis, illustrating the pathological overlap between these conditions. Next, comparative pathological summary. Feature. Key definition. Permanent dilation in bronchiectasis, emphysema, wall destruction. In lung carcinoma, it is malignant growth. The gross features of bronchiectasis are dilated pus-filled tubes. In case of emphysema, the large and pale air spaces are present. In case of lung carcinoma, gray-white firm mass. The microscopic features of bronchiectasis are chronic inflammation. In case of emphysema, it is ruptured septa. In case of lung carcinoma, dysplasia or malignant cells. The location of bronchiectasis is mainly in lower lobes. In case of emphysema, it is upper lower lobes, and in case of lung carcinoma, central or peripheral. Conclusion. Key takeaways. Bronchiectasis and emphysema represent permanent anatomical changes in response to chronic injury, necessitating early intervention to prevent respiratory failure. Malignancy must always be ruled out in chronic lung disease cases, especially where obstructive symptoms develop rapidly. Detailed morphological study gross remains essential for accurate staging and treatment planning in pulmonary oncology. Thank you.